Adonis Farah. I'm a psychiatrist from the Psych Guru, and I'll talk about the clozapine and the cardiac adverse effects of clozapine, which is myocarditis and cardiomyopathy. These are rare side effects that can happen in patients treated with clozapine. So clozapine is a complex drug. It affects multiple receptor complexes like alpha-1, alpha-2, all the D receptors, D1, D2, D3, and D4, all the serotonin receptors, 5-HT1A, and even more than these receptors, such as receptor X here in this slide, is the one that causes hyperinsulinemia in the metabolic syndrome. Now, who gets clozapine? Patients who have a suboptimal response to adequate trials of two first-line antipsychotics. And these are haloperidol, loxapine, perfenazine, quetiapine, and risperdal. And an adequate trial to determine clozapine's effectiveness is 3 to 6 months. Cardiomyopathy is the one of the few side effects related to cardiovascular system in patients who use clozapine. Between the United States, between the U.S. approval of clozapine in September 1989 and December 2 of 1999, the FDA received reports of 28 cases of myocarditis, including 18 deaths and 41 cases of cardiomyopathy. Incidence of myocarditis or cardiomyopathy in clozapine-treated patients has increased slightly over the years. In this graph we have from 1997 until 2012, and we can see a gradual increase in incidence of myocarditis and cardiomyopathy. But overall, these two conditions have a very low risk of 0.015 to 0.188%. Trends in clozapine prescribing. The percentage of schizophrenia patients receiving clozapine rose from 9% in 1996 to 10.1% in 2007. And in the same period, the percentage of patients having clozapine treatment augmented with another antipsychotic increased from 43.1% to 64.2%. So it's a 20% increase of polypharmacy. Now, nowadays psychiatrists are somewhat more hesitant to prescribe clozapine, and although the percentage of schizophrenia patients receiving clozapine increased between 1996 and 2007, the time from the diagnosis of schizophrenia, when the patient was the first diagnosed with schizophrenia, until the first prescription of clozapine increased. And we can see in this graph, compared to 1996 cohort, in 2003, it takes a longer time between the diagnosis of schizophrenia until patients are actually started on clozapine. And that's because of psychiatrists being mindful about the adverse effects. Etiology of clozapine-induced myocarditis, in short, is not known, but several theories exist. Inflammation or inflammatory theory note that clozapine increases the inflammatory cytokines. Some authors believe that is the TNF or tumor necrosing factor alpha and other inflammatory cytokines that contribute to myocarditis. Another theory is the allergy. And this theory is here because of the presence of peripheral eosinophilia on autopsy, including eosinophilic infiltrates in myocardial and perivascular areas. So these facts suggest that there may be a hypereosinophilic syndrome which is mediated by clozapine. And another theory is the toxicity. There was much talk about the direct toxicity of clozapine on cardiac monocytes. Now, the histopathological features of clozapine-induced myocarditis, as we see in this slide, includes myocytolysis and necrosis with infiltrates consisting of lymphocytes, neutrophils, eosinophils. Now, cardiovascular adverse effects of clozapine are tachycardia, which may be caused by the anticholinergic activity, orthostatic hypotension caused by alpha-adrenergic blockade, myocarditis, cardiomyopathy, and pericarditis, which have an unknown etiology. Now, tips for clinicians. At the present, there is no proven method for either predicting or preventing the development of myocarditis, although a new protocol may be introduced. But patients who have persistent tachycardia at rest, especially during the first 2 months of treatment, should be closely monitored for other signs and symptoms of cardiomyopathy or myocarditis. And if myocarditis or cardiomyopathy are suspected, then the patient should stop taking the clozapine and undergo a cardiologic evaluation. And of course, these patients who are at risk or who developed myocarditis or cardiomyopathy should not be re-exposed to clozapine. Now there's more tips, including that you can see in this slide, including flu-like symptoms, unexplained fever, fatigue, lethargy, chest discomfort, respiratory symptoms, cardiovascular signs, chest x-ray changes. Now, many of these signs are not specific, but if they occur in a clozapine treated patient, especially if the onset is unexpected or sudden, suspicion should be raised and followed by prompt cardiology assessment. There's a new monitoring protocol for clozapine-induced myocarditis that emerged from a study published in Australia in 2011, which showed that in 90% of patients, troponin was increased at least twice. And a few cases had increase of C-reactive protein to more than 100 milligrams per liter. So a proposed protocol include a baseline troponin I and T screening, C-reactive protein at day 7, 14, 21, and 28, and echocardiography or a baseline echocardiography. According to this protocol, clozapine should be stopped if the troponin is more than twice the upper limit or the C-reactive protein is over 100 milligrams per liter. Combining these two parameters has an estimated sensitivity for clozapine-induced myocarditis of 100%. However, the sensitivity for asymptomatic disease is not known.